Our next speaker is Professor M. Joseph John. Joseph is another member of the Ascot Brigade. He is on the disease-specific working group for anticoagulation, and it has been very nice being able to get to know Joseph over recent months. He is the head of the Department of Clinical Haematology and Bone Marrow Transplant at the Christian Medical College and Hospital in India. And it is fantastic to see him again. And we really look forward to his presentation today. Thank you, Joseph.
Thank you, Jason. And it was a pleasure listening to all of you and get updated really like a whirlwind. And my head is still spinning from all the information which I have got. And you were saying that you're going to get a thunderstorm there. So you named it aptly there. So my role is to give you an approach to thromboprophylaxis. What should be used in COVID-19? I'll just give you a bird's eye view on most of the things which I was thinking about. So if you have to look at the COVID-19 states, if you have a suspect, if he could be on no medications, he could be on an antiplatelet, he could be on oral anticoagulant, or he could be on aspirin plus oral anticoagulant. We test him, he could be positive or negative. If he's negative, he goes home. If he's positive, he's got mild symptoms, again, he's still going home, because most of the approaches in anticoagulant is hospitalized versus non-hospitalized. That's the reason why I am impressing upon this point. He is positive and he has to be hospitalized. Now we have two states in him. One is with moderate symptoms and one with severe symptoms, because most of the trials are looking at either moderate or severe, or either critically ill or non-critically or acutely ill. So moderate is called otherwise acutely ill, severe is called critically ill. You can have a situation where the moderate becomes a critically ill patient as well. They can get into recovery state and subsequently they can get home, because now we need to make a decision whether they need to be on anticoagulation or not, or they may not make it. So these are the states. The blue arrows will tell us what strategies to use at that in these areas based upon how the entry of the patient is going to be. What is the evidence at each level? That's the question we're going to ask. When we're asking questions, we need to find out what are the alternatives we have, and we have the antiplatelets and the anticoagulants. And among them, unfractionated, low molecular weight, and fondaparinux and the NOACs. Thrombolytic, surgical intervention, mechanical intervention, let us keep it aside for the time being. Now, from the patient's point of view, among the alternatives, we need to find out the dose, the drug, and the duration. The things we are looking at is the recent history of bleeding. If we had underlying bleeding disorder, any history of thrombosis, obese, non-obese, because if you want to choose the low molecular weight heparin, we need to have that as a reference point. What is the creatinine clearance? Because your low molecular heparin is going to direct based on that. If the patient is already on oral anticoagulants, aspirin, what are the comorbidities? What are the prior history of hit and exposure to heparin? And what's the platelet count? Because these are the decision-making points at the bedside before we choose. Now, it's a busy slide with so many questions to be answered, and we'll try and answer. My aim is to look at and say how many of them can be answered conclusively, how many of them a priori, and what is the most logical thing to do. So the first question we ask is the basic question: is thromboprophylaxis necessary or not? Is there a laboratory test needed or not? Now, a lot of observation studies have come through in the last 1 year, 2021, if you say, on the thrombo-inflammatory process which is going on. And there is no doubt, and it is proven beyond doubt, that there is thrombo-inflammation going on. And in fact, it is called COVID coagulopathy, COVID-associated coagulopathy as well, with micro and macrovascular thrombosis leading to a multi-organ failure. That's the endpoint in which we are looking at from the spectrum of the patient. And there are platelet leukocyte aggregates and thromboxane E2 generation, and so a consideration of aspirin is considered. Now, the evidence of thrombosis in COVID is quite large. If you didn't do a screening, you would get about 14%, as opposed to non-COVID patients having 1/4 or 1/5 of the incidence. If you did a screening and looked for it, you would get 40, and in some studies, even 60%. And we have enough data to say that if you anticoagulated sepsis patients who had thrombosis, you could reduce the mortality significantly, and hence the whole notion of should we prophylax patients with COVID infection. So the question is, should the thromboprophylaxis be given to hospitalized or non-hospitalized patient, and with or without laboratory testing? It's logical thing to ask, should I do D-dimer to guide us whether to do or not? And there is currently insufficient data to suggest that when the patients are sent home, you anticoagulate them or to do a D-dimer. So in effect, somebody is positive with mild symptoms, he goes home without any anticoagulation, without any test to be performed. However, if he is acutely ill or critically ill, do we need to give? And we have options of low molecular weight, unfractionated, and NOACs. Among them, NOACs is left aside because of the interactions it could have with various other medications. And there are renal failure issues which can come up in patients with COVID infection. And hence NOACs are not really in the forerunners of evaluation in COVID, especially in hospitalized patients. Then it is a toss-up between low molecular weight heparin and unfractionated heparin. And it is with or without aspirin is the questions we have. Among these unfractionated and low molecular weight heparin has an edge over unfractionated heparin because the contact time for the nurse and the patient is less as compared to unfractionated, which has to be on a continuous infusion or maybe intermittent, but monitoring issues may be a concern because of multiple bookings required for the APTT monitoring. Whereas on the low molecular heparin side, we don't have to do that. So now the question is, low molecular heparin, whether prophylactic, intermediate dose of therapeutic with or without aspirin in acutely ill or critically ill patients or moderate or severe symptoms. Now, the answer we need to look at is based upon the risk of efficacy and safety. So efficacy is the amount of thrombosis which could be reduced, and safety is amount of major bleeds which it can cause. The jury is out as of February 8th, 2021. That is the ASH guideline, which is based upon the multi-platform study which came up, mentioning that prophylactic therapy is the best way forward with regarding to critically ill patients, and therapeutic intensity can be given for patients who are non-critically ill or acutely ill patients. The listeners should go through, they understand the words of acutely ill and critically ill, because in various trials, acutely ill is equivalent to moderately ill, and critically ill is equivalent to severely ill. So that's the terminologies we are grappling with, and the endpoints of some of these studies may be different. I'll come to that. So for the time being, there was a recommendation saying that therapeutic dose should not be administered in critically ill patients because the incidence of bleeding was much higher, although the thrombotic episodes were slightly on the lower side. However, there was another retrospective study by Pubmed and group which came up with saying that the mortality rate did not differ. In fact, the mechanically ill patients, mechanically ventilated patients who were anticoagulated were better off than the others. So there is a little bit of conflict of reports which is coming in. And this is the study which is being quoted avidly with regard to anticoagulation, the multi-platform RCT study. And most of the studies, if you look at it, if you look at the meta-analysis, almost 95% to 98%, and I could get only about 12 RCTs which were done in anticoagulation studies, but that will not really comprehensive for anticoagulation alone. So these three studies with the ATT-ACC and REMAP-CAP, which we got alluded to at various studies and various presentations and active foray. So they were asking the question, by combining these harmonized protocols, and it was an open label and adaptive Bayesian trial, and which we are going to see that in COVID has brought in this entire spectrum of adaptive trials as compared to the usual designs. So it looked at decision rules of superiority, inferiority, or futility. Based on this interim analysis, there was a proposal saying that which should not give therapeutic dose to particularly ill patients. Their endpoints were need for organ support over 21 days in moderately or critically ill patients. And critically ill was defined by patients on mechanical ventilation, vasopressor therapy, or extracorporeal membrane oxygen. Then the DSMB accepted all the three platforms. They looked at the various data and they found that among the severe patients, the organ failure rates were not much different as compared to moderate. It was making a difference in the therapeutic dose arm. So the severe states, it proved a futility, and hence the recommendation came that we should not be giving therapeutic dose anticoagulation in critically ill patients. And the major bleedings were more, although the absolute, this is almost 100% increase with regarding to therapeutic dose, relative risk will be 2. However, if you look at the absolute risk is just 1.5, 1.8, 1.6. Thrombotic events were actually lesser in the therapeutic anticoagulation group in the severe state, and the absolute reduction was about 5 to 6. So, however, the statistically, the futility of the therapeutic anticoagulation on patients on organ support was a concern. How should we manage the patients with therapeutic anticoagulation? Moderately. So, if the patient is already in moderate group, moderately ill, and he happens to be in the therapeutic anticoagulation group, since there is uncertainty now, the recommendation is to continue with the therapeutic anticoagulation if a moderately ill patient converts to a severely ill patient or a critically ill patient. From that contradictory study which we talked about, there is a therapeutic arm or therapeutic anticoagulation showed improvement in another study, which now throws the open question that is it really that can we go by one study, or do we need to look at more studies? There are many more unanswered questions, and if you look at the possible combinations to actually in search for the answers, you have a coagulation. So the questions we ask is, do I need to do coagulation test, low dose prophylaxis or prophylactic dose, or prophylaxis with low dose prophylaxis with aspirin, intermediate dose with or without or with aspirin, or therapeutic dose of NOAC. You can have the clinical states as the outpatient, as I mentioned, the moderately ill, severely ill, confirmed VT, suspected VT, confirmed VT. You could get almost 56 positions we need to find answers for. And there is no data for 51% of them. And hence, more RCTs are required. And I'll come to that, how many number of RCTs are being registered now to answer these questions. So we know for sure that in moderately ill, you must give prophylactic dose at least. Severely ill, you must give prophylactic dose. There is conflicting data in the therapeutic dose in the severely ill patients. And in certain studies, there is conflicting. And hence, ASCOT is trying to answer these 5 states. In fact, these are the 5 states. Zoe is leading the working group. And these are the 5 states being looked at. And we are hoping that we will get more answers there. Various designs of studies have come in as observational or randomized, and groups, sequential or adaptive designs, as we are looking at in the ASCOT and most of the studies which you have seen. And of course, with interim analysis stopping also. There's a new trend in the design of the study to answer quickly. It is also important for us, while interpreting these papers, to look at what is the decision-making elements or the endpoints. What are the hard endpoints, which is surrogate endpoints? One is, of course, thrombosis, organ support free days, mortality, length in the ICU, hospital admission days, and PF ratio, ventilator free days. From the efficacy point of view, in safety, various other methods are used by major bleeds, minor bleeds, clinically relevant, non-major bleeds, and HIT. Cost and convenience is not taken into account, but I guess once we answer these efficacy and safety points, cost and convenience would be the next thing to ask for. Looking at the clinical trials.gov, looking at anticoagulation and COVID alone, you see that more than 59 clinically registered trials are there. About 42 interventional trials are going on. Recruiting ones are 36. It is interesting to know that there are about 4,800 trials on COVID so far going on, and 1.2 are with anticoagulation. So if you look at the spread of the trials across the world. United States leads, and of course, Australia and India has one each, basically with ASCOT and another one from PGI looking at a different angle of anticoagulation. That's spread across the world. You see that United States leads it. It is across the meridian here. It is a half cut here, but entire China is nobody is looking at anticoagulation. Neither is Africa. They may be doing that, but not registered in IH. Of the 8 completed studies, no results were available in that group. But however, there are some publications which have come. I'll come to that. If you look at the Pubmed literature, it's very interesting to see that there are more than 1 lakh on COVID hit, and about 629 studies published on COVID and anticoagulation. And in 2020-21 itself, there are 342 publications on anticoagulation in COVID, which is 6.3 publications per day. So you can imagine the load at which we need to screen the literature to understand what decision to make. When it comes to thromboprophylaxis, there are 63 publications already this year, which is about more than a publication a day. So the best then to look at when there are uncertainty and there is a load of literature which is hitting you every day, the best is to look at the guidance documents. And this is the sequential manner in which, by the sorting from the last to the latest, is the NIH guidelines which have come in antithrombotic therapy. I thought it is best to give the viewers that gist to take home. And ASH guidelines have come. Most of them are basically dealt with the input from these studies which I mentioned. So that's the NIH guideline. So in terms of coagulation markers monitoring, the answer is non-hospitalized patients do not do. Neither hospitalized patients we do not need unless you are doing it on a regular basis. And the level of literature is basically, it's a strong recommendation. However, the level is only expert opinion. Number 3 means expert opinion. If you look at the way it is, the number 3 is expert opinion, is a strong expert opinion. And in fact, in most of the recommendations, it is either a strong expert opinion or a moderate expert opinion, because there is not enough data to support this, unlike Bala has shown solid data with regarding to steroids. Routine screening for DVT, do I need to do Doppler on all my COVID patients? The answer is no, unless there is a rapid deterioration, and if you suspect, do not do Doppler testing. What is the selection of anticoagulant? The answer is low molecular heparin for the reasons I mentioned, because less of contact time for the patient to be interacted with and no monitoring required. If the patient is already on an anticoagulant, continue with warfarin if they are on. And if they are already on anticoagulant or antiplatelet, continue that unless there is significant bleeding. Again, a strong expert opinion. COVID-19 were managed in outpatients, non-hospitalized patients do not start on VTE as of now. Hospitalized patients, start with prophylactic dose for sure. If you want to do therapeutic dosing, especially in critically ill, under a clinical trial, that could be a best option. And if there is thromboembolic event, then therapeutic dose is warranted. Again, a strong expert opinion. And of course, with the renal replacement, local standards. In children, especially, there is not much of studies. If you look at it in children, 1 or 2 studies only, and the indications are similar to other kind of patients without COVID. Post-discharge prophylaxis. This is a moot point, because some of the patients coming back within a week with an MI or a post-convalescent MI situation. However, current recommendation is at discharge, do not give VTE prophylaxis. However, if there are high risk and if the clinician feels there are high risk, rivaroxaban at a dose of 10 mg may be given for about 30 to 40 days. In terms of pregnancy, prior to a diagnosis of COVID, this therapy should be continued. And however, in most of the pregnancy situations, it is a similar strategy which we take with anticoagulation otherwise. Lactation, of course, the DOACs or NOACs are avoided because it can have breast milk secretion. However, low molecular heparin and warfarin are safe. So when we come back to the grid where the unanswered question, pregnancy and lactation, I have added along with the other ones I have added. There is no data in certain areas, but the green ones, at least we know for sure that can be followed. And where there is conflicting data, we need to have studies in that. That's why the ASCOT is doing this study. We still have uncertainties and probabilities. And when we look at thromboprophylaxis, it's a swinging pendulum between uncertainty and probabilities.
Thanks very much for all of your presentation, also your commitment to trying to provide that research to answer all those uncertainties which you highlighted. Thank you.